Good morning to those of you on the East Coast and Central Time, and good morning to those of you Mountain Time and Pacific Time. Welcome to today's webinar, and we're delighted to have you, the Culturally Sensitive Psychoeducational Services for Hispanic Unaccompanied Children. I'm Luis Zayas, and I'll be the moderator for today's webinar. I am also Dean of the Steve Hicks School of Social Work at the University of Texas at Austin, and I'll be one of today's presenters. The only housekeeping item we have right now is we ask that you hold your questions till the end after our third speaker, and we can then answer your questions and engage in what we hope will be a lively conversation. To open today's webinar, I want to introduce Dr. Rocky Romero. Dr. Romero is President and CEO of J.R. Romero and Associates, a training and consulting company that he began many years ago. He's also formerly an assistant professor of social work at New Mexico Highlands University. And without further ado, I give to you Dr. Romero.
Well, thank you, Dr. Zayas, for the introduction. I want to welcome everybody to today's conversation and hopefully the beginning of many more conversations around a very important topic. I want to welcome you all to our presentation today. Again, cultural values and idioms of distress in the Hispanic and Latino populations. I'll be talking to you all today about the role protective factors play and risk factors play, especially with regard to unaccompanied minors and Latino children experiencing immigration and acculturation. So for our time together today, I'll be looking at the two learning objectives that are outlined here. The first one is to describe the cultural concepts of distress and values unique to Hispanic and Latino communities. Number two, discuss the pertinence of cultural idioms of distress in mental health treatment, and understand challenges Hispanic and Latino populations may face. With that said, we also have to understand and say thank you to our sponsors and organizers of today's training. We're thankful for the opportunity to present to you all today. It looks like we have quite a few attendees, and we're happy that you joined us. So to start out with some topics or concepts that you may be familiar with, we have the English and the Spanish version of these, which we look at as some of the basic cultural elements that help to create an effective therapeutic relationship, as well as a client relationship that looks really at familism or familismo. Looks at things from a respectful or respeto type of relationship. Personalismo or developing personalism, personalized relationships, creating a familiar space through that respect. We also look at confianza or trust. And confianza or trust, I believe, is a cornerstone of these concepts that we're introducing to you all today. Some of you may have received our training prior to, and some of you may be coming to the training for the first time, looking at these cultural elements that we feel are again, the cornerstone of building relationship with Latino populations, especially those that have experienced trauma and adverse childhood experiences as well. The other one that we look at here is espiritualidad or spirituality. We don't necessarily get into religious aspects. However, if the client presents that way, and one tool we feel is extremely useful for appropriately and culturally assessing appropriateness of services is the cultural formulation interview that is a part of the DSM-5 and in the appendices, and can add a component of screening to your interaction with those individuals who are immigrating to this country, seeking asylum and or have experienced, again, traumatic events along that way. Last, and I'm very excited to add this component to our conversation, is traditional healing or curanderismo, or healing men or women within traditional or indigenous communities. Many times Latino populations, especially family members, grandparents, and parents, will take young children to visit with curanderos or curanderas in order to get relief from certain ailments that many times in Western medicine, that would be the approach, is to seek a doctor, a primary care physician, and to get medication potentially, and or seek services that way. We have to truly engage. If we're thinking about a whole person concept, we really have to engage traditional healing if the family or individual presents that in your initial intake and assessment of the population we're discussing here today. So getting into a little bit of breakdown of each of these, we talk about familia or familismo, describe the client's focus on family and their community as a source of identity and support. We see that very often where a comadre or compadre, right? Even if it's not somebody that's blood related to a family, they always have a friend, a family friend, somebody that's close to them, a confidant that they can reach out to and discuss their issues, their stressors, family issues that come up. So many times those are the less formal approaches that families will use before going to seek more of a structured environment like mental health and or crisis services, treatment services, addiction and substance use services, etc. Within those systems, the boundaries may be flexible between family members. Again, I think we have to be cautious that I talked about this a lot in a topic that I present on, looking at the intersections of racism and mental health with the Latino population. And we see that often clinicians coming from a Western model approach tend to pathologize or start to want to diagnose symptoms that may be related to discrimination or oppression, not necessarily trauma initially, but some of the discriminatory experiences that the Latino population may have experienced, whether that's through their immigration journey and or through their time spent in the United States. The third bullet here that we look at is we want to really provide a flexible understanding of the boundaries and realize that we have to understand the many systems that families and individuals are involved with. And many times those can be sources of not only, again, familiarism, but also an attempt to leverage more support for the individual family system that you may be serving. Respeto or respect, I think this is the cornerstone of any relationship. Similarly, in the Hispanic and Latino populations, respect is a cornerstone of any relationship. So we feel that as we got through the introduction, the center, the MHTTC, and all the centers that are funded through SAMHSA take on a client-centered language approach. And I think if we start realizing the language that we use to address populations that we're serving come from a place of respect and humanism and compassion, rather than clinical diagnosis and or terms where we see that it can create a feeling of discriminatory oppression when we're looking at terms like illegal alien, or when we see terms like immigrants connected to criminal, right? And we see a lot of that presented in our headlines or through some of our government language that has been used, especially in the prior 4 years in the United States. Looking at respeto refers to respect given to professionals. Sometimes that means, however, that families and individuals you serve, they may also take a back seat or step away, feeling that they may impact the professional interaction that you're trying to engage with their loved one. And we have to remind them that family support is at the cornerstone of successful treatment outcomes, as we see research pointing to in the data. With that said, encouraging and inviting family members to participate in treatment. However, as many of you know that do work with the Latino and Hispanic populations, you have to be ready for that, meaning that if there's interpreters that are needed, you need to leverage that resource. If you need bigger space because of COVID restrictions now, because it tends to be when you invite a family member in, you invite 1 or 2 members and you'll have 3 or 4 or 5 show up if you're really developing this respect with families. And to me, that is a beautiful thing to see when you're trying to engage Hispanic and Latino populations. And then again, expression of respect through titles, formal titles, yes sir, no ma'am. I think those are definitely a sign of respect in any culture. And I definitely see that in my culture, in the Latino culture, as signs of respect as well. Personalism or personalismo really creates and tries to work from I would say, when we're looking at clinical models, a motivational interview, client-centered, Rogerian underpinning approach, where we start where the client is. We create, and when we talk about this in many Latino cultures, they call it platicar, right? Or the conversation. Before we get into the diagnosis and assessment of individuals, let's take some time to have some platicar to get to know them. Oral history is a cornerstone of cultural values within the Latino and indigenous populations, and really developing that as an approach within your own toolkit and your own agency's approaches to developing therapeutic or excessive access to services are important factors that we definitely want to recommend to you all today. The second bullet that we see here is client or patients, again, may expect providers to demonstrate sympathia or kindness, and which human being does not expect that from their provider, right? So I don't think that that's anything new, but I believe that we have to be reminded of that continually, especially for those of you healthcare providers, and I give you all the respect in the world, given your service over the last year and a half and before and after COVID, that really is displaying this in practical application, right? Meaning that you are the people that are showing kindness and are showing personalismo, and I think can help build these relationships to further engage our clients within the treatment services that they're needing, and or within the other mental health medical services that they may need. Confianza or trust, building trust. I think just like any other therapeutic model we see, we believe that at the foundation of a model, you have to be able to build trust with the clients that are receiving that. And that means trust through reciprocity, right? Trust goes both ways, to not only client to clinician or provider, but obviously to provider to clinician as well. Mutual reciprocity in the relationship must be emphasized and respected and expected. And then I think the small disclosures bullet here, I would recommend that you do that as appropriate within the specific model that you're using. As many of you know, and I'll use an addiction treatment model or substance use and abuse model like the matrix model. That model tends to not want to utilize a lot of self-disclosures, but it still does have a therapeutic relationship building as a building block of that model as well. So with the center's availability to you all as providers, we can also go in and help you develop and adapt evidence-based models that maybe were created in with different populations, and we can help to adapt that to make it more culturally viable and appropriate for your population as well. So I hope you reach out to us at the end of our presentation and as the series progresses. The next one that we look at here is espiritualidad or spirituality. So really looking at the express of the belief of the individual, and really that sometimes people will have or think of their perceived fate as an individual. So things that are happening to them that may be in many respects just life happening, they may attribute that to their fate, to the fact that they've done certain behaviors that may be not appropriate, maybe things that go against their religious beliefs or their spiritual beliefs, and they feel that in some way what they're experiencing, mental health or medical physical ailments, may be directed to a penance, if you will, or punishment. We definitely have to understand that very often members of the Latino community, especially our grandparents and parents, those that are more traditional, will seek religious leaders in their community that practice or connect to them at that level prior to seeking mental health providers and or substance use providers and or medical providers. So we have to value that and not take a position like we don't recommend that, or that is not something that we want to work with. I think if we're trying to be culturally appropriate and sensitive, we have to engage with this other level of healing that may be rooted in traditional beliefs for 500, 600, 700 years historically. And we have to respect that if we are embedding these concepts within our approaches. Lastly, we look at traditional healing. And a couple of idioms of distress that we start to look at are susto and pacho, mal de ojo, and I'll talk a little bit about those also before my time. And I think I have about 5 minutes left, so I'll be transitioning here very soon. Traditional healing is something that we look at that is extremely important. When we look at curanderismo or healers in the community, they look at addressing susto or fright in the translation. Empacho empacho is one of the symptoms of kind of feeling like somebody is stuck with emotions, with certain intestinal functions, and we see that they go to healers to try to get those functions to start to move appropriately as well before they go to a medical doctor, provider. And many times there's herbs or remedies that are given. Mal de ojo, this is something that is almost like envidia or taking possession through jealousy of usually of a child or an infant, when the person that maybe is giving that bad look or bad eye to the child, and it takes on a whole other physical symptomatology as well. Curanderos, brujos, espiritualidad, yerberos, limpias are a part of a practice as practiced by curanderos that we have to understand. Sometimes that's a cleansing. Sometimes curanderas will go into the home and use a sage to burn, and that is also done through the body, where the smoke of the sage is presented and covered over the whole body, and other practices similar to that I hope as we expand our conversation with you all, we're able to bring some of those practices to light for you. We definitely want to look at these three clusters of symptomatology and explanations for the experiences that Latinx populations may serve. We look at cultural idioms of distress. So these are the symptoms and how they are expressed by a collective group of people. So when we look at immigrants or unaccompanied minors now that are coming to the United States, they all are sharing experiences of trauma, of experiencing death along the way, experiencing violence, unfortunately, and I'm sorry to be so graphic, but experiencing rape along the way for many of our minors. And we have to look at that as those adverse childhood experiences that are being experienced along that journey. Labels, attributions, or features are the cultural explanations that we want you to think about. So looking at, again, mal de ojo or susto, fright. Susto or fright to me is when someone sees a traumatic experience or event right in front of them, somebody getting killed or somebody being traumatically beaten or violently attacked. Those can carry kind of this, to me, it's also the equivalent of Western medicine's shock, if you will, when someone is in shock. And then cultural syndromes are the symptoms and signs that occur among individuals that are part of specific groups of people and populations. The idioms of distress we look at are, again, ways that the Latinx population or Latino population defines specific expression of affliction. These idioms matter when the provider wants to provide a cultural sensitive treatment, and it's also a way to help them address and attach some of these meanings to maybe more Western medicine diagnosis if that's the event that needs to take place as you diagnose and do an appropriate culturally sensitive intake and assessment with our clients. We truly feel that if you don't take a cultural formulation interview approach or use a interview process that is culturally aware and sensitive, we may misdiagnose Latinx population and Latinos, and especially our unaccompanied minors that are coming in. And we want to be cautious in that before we make a mistake of assigning them a label that may carry with them throughout their acculturation process in the United States. Nervios, we talked about this. This can be very similar related to nerves or anxiety. Ataque de nervios is obviously another one that we look at. It's general vulnerability or stressful experiences, and they'll talk about that, or they'll explain it to you that way when they're explaining their symptoms. Again, ataque de nervios are more of the physical symptomatology that is played out. Sometimes it can be played out through screaming or shouting or crying out loud unexplainably. And as a clinician that's doing a culturally appropriate intake and assessment, we want to think about these things as we work with our Latinx populations, especially our unaccompanied minors that, again, are coming in at elementary school age all the way into junior high and high school age years, as you'll hear Dr. Zayas talk about and Dr. Orengo Aguayo also talk about here shortly. Susto, and this is the one I mentioned that usually reminds me of fright or shock. We also have to think about how these symptoms are played out through experiences of acculturation, discrimination, oppression, and stigma. And that is my time for right now with you all. Thank you. And we ask you guys again to please complete the surveys. I think those are things that we ask you to do so that we can continue to provide these quality trainings to you and at a free rate and try to do that in a way that is appropriate for the services that you provide. Dr. Zayas, thank you again for the introduction. I'll turn it back to you and we'll get into the next presenter.
Thank you very much, Dr. Romero. Actually, I am the next presenter, and it's great to transition from your talk into mine. I am now going to, is my screen being shared with you now? Someone say yes?
Yes, sir.
Okay, thank you. So thanks again, Dr. Romero. I have a chance here to speak to you about one of the many mental health issues that we will see arising in the context of children who come here unaccompanied or who came here with their families and then were made unaccompanied minors by government decree, if you will. And so I want to tell you something about that and just focus in on this element. But remember, there are many more elements in the reactions that kids have to separation, detention and separation. And before I go on, I want to tell you that there will be some images here and videos that I'll be showing that may be upsetting to some of you. So I give you a warning that you should use your discretion on this. I want to quickly go through the fact that we have pre-migration stress and trauma. We have the trauma and stress that happens as children from Central America get here to the United States, and then the post-migration trauma and stress that we know, and many of us know that children and families have spent time in hieleras, the so-called ice boxes. They spent time in perreras, the chain link fences, enclosures that they're in, and of course they spend time in some form of detention or other, whether it's in unaccompanied minor only places or those where they share with their families. So when we go to the pre-migration trauma, these are some of the images that we've all seen at some point or other, and this is these are the kinds of scenes that kids actually see. And just so that we have a clear understanding, witnessing death, seeing a dead body, or witnessing someone who is at that moment being severely injured is one of the highest burdens to PTSD. It's one of the things that affects memory and helplessness. It has long symptom duration. It sticks around with us for the longest time. So when Dr. Romero said, you know what, being a witness or victim to these events can be terribly traumatizing. But let me just show you what a little boy drew for me in an interview I did with him in a detention center where he was with his mother. So this is his town, and his town was terrorized by the rebos locos, as he called them. And in his drawing, he's showing me, he's about 7.5 years old at the time. He's showing me that the bad guys smoke cigarettes. They smoke cigarettes. They have firearms. They set houses on fire. You can see at the bottom right, there are people who are dead on the ground. In that case, it might even be a coffin. And these are the marauders of the neighborhoods. This is what Danny was exposed to. And at one point, one of those rebels locos, a teenager, beat Danny up pretty severely. And at that time, he was 6 years old, a little older than 6 years old. So that's the kind of pre-migration stress and trauma that was all-encompassing, if you will. It occurred in their town. It wasn't just yet directed necessarily to Danny. However, it got to him. In this scene, the horrified son is watching what happened to his own family. His uncle, mi tío, over on the middle to the left, is on the ground, having been shot in the face by the Rebos Locos. He also has them shooting at birds. At the top are his grandparents, wailing and crying that their son has been killed. And at the bottom right is his mother, who's distressed about the loss of her brother, because they all live nearby. Danny tells me he ran over to see his uncle, and he remembered seeing the disfigured face and the teeth of his uncle coming out of the back of his head. Again, look at the horrified son. We know that children's drawings tell us something about their internal functioning, and this is a perfect case in point. If you want to know the full story of Danny, you can see, I describe it in my TED Talk, which you can find easily, just TED.com and my name. Just at one quick point, his father was a single leg amputee and was not able to escape from the town and the Rebos Locos. That's the kind of things that our kids will be bringing to us. That doesn't even include what happens along the way. So let me then jump right ahead to the points I want to make on the mental health effects. When we separate parents from children, rip them out of their arms suddenly without any warning, especially the younger children, we're going to affect their attachment. Now, we all should know that attachment is the fundamental human bond. It's parent and child, mother and child most often, that really creates a sense of internal coherence for the child, a schema in which they know that they will be cared for and that someone will be there to protect them. And so when that human attachment is ruptured through separation, for example, sudden separation, it can lead to reactive attachments problems, okay? One of the ones that's well known is a child who responds with insecure and avoidant attachment. That is, the child is still attached, but it's an insecure attachment, not a secure one. And so what we have when that attachment, rather when the reunification occurs, is that the child will expect to be rejected again by their parent and will demonstrate avoidance rather than proximity seeking. That is, they'll avoid their parents because they don't know if they're going to be rejected. And by staying away from their parents, they're able to reduce the anticipated conflict with their parent or their rejection. In this next slide, you're going to see a little boy who's being reunited with his mother at Bush International Airport in Houston. He was reuniting now after 3 months of separation, after he, his mom, his father, and his little sister had come across the border. This is back in 2018. His father and he were sent to one detention center where they were then subsequently separated. The mom went to another detention center with the baby girl. And if you see here, you watch this little boy reject his mom. You think for a moment he's going to seek his father's connection, but not even that. This boy's attachment reaction is quite severe. Here you go. You can see how this little boy simply doesn't know, cannot be with his mother after what he perceives as abandonment, right? That she left him, and he doesn't understand. You can see he's a toddler, in fact, and doesn't really know. And there's really no attachment to his mom. He's not that attached to his father, although he was reunited with his father first before they all met. And you see the father clutching his little girl whom he hasn't seen for 3 months. That's one sort of reaction that we might witness in the case of a child who's been separated. We are talking here about young children. but the attachment disorders occur throughout the lifespan. Another form of a problem, or one of the consequences of separation, is called insecure ambivalent attachment, where the child has had some experience of separation from a parent who took care of him, loved him, and so on. But in this case, whereas the other child was really avoidant, just avoiding mom, and didn't understand why she had left him and didn't want to be comforted by her, did not want to be rejected by her again, he flees. In this case, the one I'm about to present to you, the child is really uncertain of the parent's response when they get together. So that's why we call it insecure ambivalent. They're not really sure. They may show passivity or anger and resistant behavior to the parent, which serves to really keep them at a distance. They may come close, but then they pull away. But that's part of the ambivalence. And when the parent responds to the child in need, the child may be ambivalent and not feel comforted at all by the parent, or might be comforted in some situations, but not others. In this next video, we see a demonstration of insecure ambivalence. It's a boy in a shelter, having been detained, separated, reunited and detained, and now released into a shelter before they go on to their destination town, wherever it is in the United States. And it's a longer video. Of course, I'm showing you just a clip. And here we see, if you watch the longer video, you see him playing with his mom. Very nice. Things are going well, the way a mom and kid might have on a normal day. But something happens. Something happens at this moment, just before this portion of the tape. We don't know what, but clearly he's reacting to it. And now he's demonstrating that insecurity and that ambivalence about his mom. And so he's really uncertain if she really loves him. And so he becomes angry and resistant. Take a listen.
Toda esta separación fue muy larga, mi vida cambió mucho. Con tanto trauma. Ya no quiero ser tu hijo, ya no soy tu hijo.
It never gets easy to watch either of these two videos, having seen them numerous times. But again, you see the reaction of this young child. It doesn't stop there. It doesn't stop at that age group. We all know that there have been occasions when a parent has come to the United States, or both parents, and left a child age 2, 3, 4, 5 in their home country while they establish a foothold here in the United States. And then they send for the child 5, 10 years later. And then there's the reunification. Everybody's looking toward it. Everybody's looking forward to it, except at the moment of the reunification. Now that 2-year-old baby is a gangly 12-year-old child, not quite the baby that they left. He looks different. Now he's approaching puberty. They might have facial hair. The child is looking at the woman and at the man that he's now reuniting with. Sometimes the parents have divorced and separated, divorced. Other parents have now taken the place, and they have got to adjust to these folks. That's also a situation where you get the problem with the attachment. How do we make attachments both ways? In the two cases we just saw, the mom was trying to connect with the child. The child did not want to connect. In the case of older children, there may be a desire to both of them to attach, but they don't know how to. It's been too long. That's where we need to consider intervention. When we think about unaccompanied children who have come here by themselves and might be reunited with their parents or an uncle or an aunt, and they're older, we can expect that there would be those reactions in that reunification. It's not just simply embracing and finding a joy ever after. So we've got to think that it's developmental level, age, and the length of time between the reunification, which is why we titled this webinar having to do with psychoeducational interventions. And let me just go on to one of the things we might think about, as we saw in these two children, are the reactive attachment disorders that we read about in the DSM manual, which really shows inhibited, emotionally withdrawn children who react as such to their parents. The very limited positive affect, episodes of unexplained irritability, sadness, or fearfulness. We might give these two boys such a diagnosis if we were diagnosing. And again, usually reactive attachment disorder occurs after a child has had the experience of neglect, deprivation, sudden, repeated changes of caregivers, or some kind of disruption. Those are probably the worst types of separation, which is the ambiguous, sudden rupture between a parent and a child. And we talk about traumatic loss, ambiguous loss, and those are the sorts of experiences that many of the kids in the centers for unaccompanied minors that we're seeing crop up all over the country and that you're serving in your communities, and we see in parents with children who were detained and at times separated. What are the long-term effects? Well, those of us who do community work will be working with these children for a long time, and we know something about the intergenerational transmission of trauma. These children, their parents, it's not going to be just their generation that will experience it. It's their children and their grandchildren. So we've got a lot of work to do in the United States and in Central America for the coming centuries, if you will. Some of the long-term effects, the constant fear of deportation. We hear it, I hear it all the time. Those memories, the traumatic memories, sudden, upsetting nightmares, night terrors, images, and some of the humiliation they may have experienced during the migration and detention. Their shattered sense of safety and well-being. Am I safe? Am I going to be taken away again? They may not be able to regulate their own stress responses. We know something about the HPA axis and the impact that has on the body when it's overworked. Difficulties with self-esteem and self-image. They have a sense of hopelessness and diminished expectations for their future. And of course, we see other functional impairments in key areas like psychological functioning, social, educational performance. So those are the sorts of things we're going to be seeing in these children. And I hope we can have some time later to discuss this a little bit more. But it's something that, as clinicians, as practitioners of all sorts, we are going to have to be dealing with in our community settings, whether it's child development centers, mental health, youth groups, recreational groups, you name it. We're going to be seeing these children in our services, and we've got to be prepared for them. With that, I thank you, and I will turn it over to Dr. Orengo, who is an assistant professor of psychiatry and behavioral sciences at the Medical University of South Carolina. Dr. Orengo, I turn it over to you.
Thank you so much, Dr. Zayas. And I will show my slides in a second once I get permission to do so. But while we do, I just really want to thank Dr. Romero and Dr. Zayas for their presentations. And it's a really nice segue to my presentation. So I don't know, Cindy, if you can give me control so I can share my slides. Yeah, it sounds like I might not have permission to share slides. Let's see what's going on. There we go. Perfect. Thank you. All right. Perfect. Well, this next portion of our panel will focus on how do we provide this information in very simple terms about the potential trauma that these kiddos, these minors might have experienced, and how do we provide this information in an easy to understand manner to sponsors who come pick up these children, or to coworkers who might be new to the field and want to learn? And what are some resources that we can use so that we don't have to reinvent the wheel and we can readily provide this information? So the first thing we need to be very clear about is, an unaccompanied minor is defined as someone who's under the age of 18 without lawful status in the U.S. and who comes to the U.S. without an accompanying parent or legal guardian. And it's important to understand that these minors are also called in different government agencies, literature, as unaccompanied alien children, UAC, or unaccompanied immigrant minors. And as Dr. Romero was pointing out, we want to use affirming, sensitive language. So for this presentation, we refer to unaccompanied minors as alien children might, as you can imagine, have a very negative connotation. As folks have been aware in multiple news outlets across the nation, we've heard about the number of unaccompanied minors growing, and in particular doubling in March of this year as the fleeing number of situations in their home country, and now the complexity of a pandemic. So the first thing we need to know when providing psychoeducation to a caregiver, to a sponsor, coworker who might not know what's quite going on with these kiddos is what they've experienced. And our presenters have mentioned this, but to recap, these minors have gone through a number of experiences that we would categorize as potentially traumatic. And a trauma is an event in which someone fears for their life or their safety or the safety of others, or has a basic need that is not unmet, or feels like their life is in danger in some way. And this can include, prior to coming to the host country, in this case the United States, lack of consistent access to caregivers, homelessness, lack of food, lack of shelter, and exposure to violence, war, gangs, and torture. So, I am a clinical psychologist and I work at the National Crime Victims Center at the Medical University of South Carolina. Our entire work is to provide evidence-based trauma-focused services. And in my experience working with unaccompanied minors and minors who have had immigrant parents, it's very common, this pattern of it's not just one of these experiences. It's like you have a bucket, and I want you to imagine that it starts filling up with water. And eventually what's going to happen, it's going to overflow. And if you don't empty that bucket, you're going to have a problem. So these minors are experiencing an accumulation of bucket experiences, lots of water pouring in the form of trauma, because during migration, they encountered very hazard conditions, potential coercion, abuse, being trafficked, seeing their friends, their journey mates being tortured or abused or even killed. And on top of that, I want you to consider the following question. Imagine in your own family, what would it take for you to decide that you were going to allow your child to leave your country unaccompanied because it's better for him or her? Imagine the level of violence, of desperation that you may be experiencing as a caregiver where you come to that decision. So this is not to be taken lightly. These are very difficult circumstances they're fleeing. And when they come to detention centers in the US or any border, they encounter sometimes unsafe conditions, that separation that Dr. Sayas talks about, which heightens that alarm system in the brain that further alerts them to, I'm in trouble. They might encounter lack of access of services in their own language and further risk of abuse. And when they're reunified with their sponsor, it might be a family member they have never met, they've only done FaceTime with or Skype or seen via WhatsApp FaceTime calls, or it might be a different idea of what they envisioned. I work a lot with adult women who are immigrants and who describe this sense of not really knowing their child when they arrive, and describe this anger that their child feels as teenagers of, why did you leave me? Why did you leave me with abuela? And lots of ruptures in communication that happen along decades, and really difficulty understanding their experiences. For those minors who aren't reunited with caregivers, family members, and are put in foster care, this brings its own challenges of perhaps being paired with a family that might not understand, might not have the background to really grasp what this child has gone through. And on top of that, we have to remember, imagine if you moved your family to Italy, Italia. Imagine enrolling your kid in the public school system in Italy. It would be different. They would encounter new foods, new customs, new different routines. This is hard. So these kids are dealing with a lot of changes, okay? So what is the impact on of trauma? And I want you to hear this next part of, like, how can I absorb this information in a way that makes sense to me so that I can be ready to talk to caregivers and coworkers about this and provide psychoeducation. So as we said, trauma is an experience that you feel like your life is in danger, the life of someone else is in danger, you're in constant panic, something horrible has happened to you, like abuse, maltreatment, grief, loss, disaster. And this could result in a number of mental health conditions, including what's called post-traumatic stress disorder. And I'm going to quickly go into this slide and we'll come back. But post-traumatic stress disorder is a constellation of behaviors and symptoms that impact how you feel, how you think, and how you behave. And the hallmark of this disorder is being exposed to a traumatic event, and then you start avoiding thinking about this event. You avoid talking about it because it's too painful. Any little noise or touch frightens you. And you know why this happens? Because these kids have been in panic alert mode for most of their lives trying to stay alive. The brain is a fascinating organ, and its job is to keep you alive. So it's going to activate your limbic system, your amygdala, and say, flee, this is danger, protect yourself. And when they're in a safer situation, those patterns of responding don't simply go away. So you see kids who are also in an irritable mood all the time. They might have negative thoughts such as life is not worth living, life is unsafe, I can never trust anyone. They're always on guard. They might start avoiding places and activities because when a trauma happens, the amygdala, your brain's alarm, is the neighbor of the hippocampus. And the hippocampus, the job of that little structure in the middle of your brain is to take a picture of everything and remember it. So it's almost like the hippocampus is telling this kid, hey, the last time we saw a group of middle-aged men who were smoking and holding and wearing hoodies, we almost died. So the next time you see middle-aged men, I suggest you run. The next time you see or smell a person that looks like the one that hurt your uncle, I want you to run. And so this is very adaptive in the moment, but you can see how it restricts their lives, and it becomes a matter of avoiding places, people, things that remind them of the event. These kids also have what's called flashbacks. It's almost like they're staring at you, but they're not there. And all their mind is showing them is a picture, a movie of the horror that they've seen. And this is the brain's way of kind of like not really resolving what happened. And that's what therapy helps a lot with. By telling their story in a safe, with a professional that knows what they're doing, these kids can organize this mess of thoughts that have come about because of the trauma. So now that we've talked about, I'm going to go back to this slide briefly. So PTSD is not the only potential effect that we see of trauma. Kids can become really sad, withdrawn. Their appetite can change. They can stop eating or overeat. They can want to be sleeping all the time. These are all symptoms of depression. They can become really anxious and worried. They can also engage in self-harm and have suicidal thoughts and want to take their lives. You know, I think the ultimate expression of desperation and the ultimate impact of trauma is thinking that there's no way out other than killing yourself. So we need to keep an eye out as well with these kiddos. On top of that, there's really long-standing literature showing that, remember that bucket? The more traumas, the more adverse childhood experiences a kid goes through, the more likely they are not just to develop mental health conditions, but also physical conditions like obesity, diabetes, cardiovascular disease. They're more likely to smoke, to use drugs, and to die prematurely. So we need to really keep this in mind when we're providing information on the effects of trauma. Another aspect of information that you might want to think about having in your back pocket is that approximately 1 in every 2 kids in the United States will experience a traumatic event before they turn 18. And on top of that, the more traumas a child experiences, that's called polyvictimization or cumulative trauma. That increases the risk of these kiddos experiencing that list of symptoms and mental health conditions and physical conditions I explained before. And sadly, we see significant disparities of trauma exposure, so that ethnic minority youth experience trauma at a higher rate and have less likelihood of accessing culturally and linguistically competent services and evidence-based services. And when they do engage in treatment, they're more likely to drop out for reasons that Dr. Romero explained, such as there's no integration of cultural values or exploration of what it means to seek mental health care and what are potential alternatives or explanations that that family has for what's going on and other methods of healing. Among unaccompanied youth in particular, we see that about half have violent exposure traumas and about 22% report fleeing an abusive home in their host country. And many of these kids are coming from countries such as Mexico, Honduras, El Salvador, and Guatemala, but that doesn't mean you're not getting an influx of other kiddos coming in through those countries. We're seeing higher rates of anxiety, depression, PTSD when you compare unaccompanied minors to accompanied minors. So even kiddos who've gone through the same horrific journeys and fleeing the same situations, having a caregiver that can protect them, that they know they have that social support, buffers some of the effects of this experience. Girls are also at higher risk of experiencing PTSD across studies in boys for a number of reasons, which many may be also how we culturally allow girls to express emotion, whereas with boys we train them not to. And longer stays in detention centers, immigration proceedings, economic hardship, and further exposure to trauma can all aggravate these outcomes. So, and also studies are finding that the length of stay of separation from a caregiver heightens anxiety and depression in these kids in the initial years after migration. So I think the other component to remember is that kids are also resilient. When we provide psychoeducation to caregivers, to sponsors, we need to remember that they're not just negative effects of this. Kids develop innate capabilities to cope. They become resourceful. You might see kids who take on more leadership roles, who learn to overcome adversity. So we also have to factor in that not every youth will end up displaying symptoms or need an intervention after this process. So concluding, how do we provide this information that I just presented to you, to caregivers, to sponsors, to coworkers who just don't know what they're seeing? The first thing is keep it simple. So I always tell my students, it's your job to really understand the information, digest it, but when you explain it, don't try to lecture. Just provide a couple of quick facts and check in. And the way that I encourage my students to do it is use one of these tip sheets. The National Child Traumatic Stress Network, the Hispanic Latino MHTTC has fact sheets. This one that I'm presenting is in Spanish, of common reactions to trauma and what is trauma. And you can sit down with that sponsor, that caregiver, and read together and then discuss, okay? So you can always use a guide, okay? The other thing that you want to do is pause as you discuss a couple of bullet points and check in. What questions do you have? And I recommend that you don't say, do you have questions, but rather say, what questions do you have, so that you invite discussion and make it clear that of course they're going to have questions and it's your job to help answer them. Check in on how that sponsor, that caregiver is feeling. For example, when I just read that some of these children witness massive violence, abuse, and might have nightmares when they sleep, What are you noticing is happening in your body right now? What are you feeling? Is there anything that's coming up for you, any thoughts? And then validate those thoughts and feelings. Yeah, it's really hard to feel that. Think of the mom that you saw in Dr. Sayas, the video, that is seeing her kid just run away from her, or the kiddo who's saying, "You're not my mom. I want to go back to jail." You know, I would check in with that mom. Mom, that can be really tough to hear. Tell me, what are you feeling right now? What are you thinking? And then I would insert some information. Did you know that most kids who go through what little Manuel has gone through experience these tantrums? They feel like a lot of emotions, and this is because of trauma exposure. Can we talk a little bit about this? Also, when you're going through these fact sheets and resources, ask, have you noticed this in your kid? Have you noticed this in Laura? So that you can use the own child's behavior that the sponsor or caregiver is observing as a point of discussion. I think the other important point is remember your role. If you're not a mental health provider, your role is not to provide advice or speculate or give diagnoses. It's to validate, listen, and provide information, and then connect to referral sources. So it's okay to stay in your lane, and I think that gives us freedom to know this is my role, and there's a next step where that sponsor can get more information or caregiver. The other thing too is help that caregiver put on their trauma-informed lenses. And what that means is if you start notice blaming, or why is this kid like this? They're already in the US, they should get it together, they should be fine, they're safe, I don't get it. Help that caregiver kind of imagine what it's like for a child to have seen so much gore and so much loss. What might they be feeling? What might they be thinking? And put on your trauma-informed lens. What has happened to this child is the big question, not what is wrong with this child. You do this through listening. And listening is something I think that in US culture, we keep losing. And we jump into advice giving or judgment. Listening means staying quiet, having open body language, and when the person is done, picking out one or two things that you can reflect back to that person. For example, wow, I can imagine that was hard to process. Thank you for sharing that. I know you're worried for this child. I admire how much you care. So imagine if you're telling your best friend something terrible and what they tell you is, well, why didn't you do this? You know, we shut off. We don't like that. But imagine your friend telling you, thank you so much for opening up to me. That's very brave. So that's how we show that we're listening, and that's how we get caregivers to open up to us and children to open up to us. Identify the strengths. For every child that is throwing a tantrum, there is a moment that they're also doing something worthy of praise. So try to help that caregiver identify strengths. If the only strength that they can find is, I don't know, I guess they're still here. Well, let's praise that. That kid has gone through something horrible and they're still here. That means that they have tools in their toolbox that we can capitalize on. Finally, instill some hope. We want to make sure that these caregivers communicate, know that you are there to help them find resources so that they can be a source of hope for these kiddos. Use certified interpreters. Prior to our webinar, we were having a really great discussion on this. Unfortunately, I wish we had more bilingual providers that spoke not just Spanish, but all the series of native languages, indigenous languages that these children speak, but we don't. And in the absence of that, the best thing that we can do is help our organizations that we work with identify certified interpreter companies via phone, via telehealth, via community liaisons, where we can have language access. I want you to imagine that you don't speak English and you go to an oncologist and your child is telling you that you're diagnosed with cancer. Imagine what it's like to have your child be put in a position of the doctor relaying that you, the mom, has cancer, and your child is put in a position to communicate that because he speaks English, not you. We can't be doing things to kids. The other thing too is interpretation is a profession. It requires skill and training. You would never want to go to a surgeon who just kind of learned what he or she did through YouTube, right? Or kind of knows the procedure through Grey's Anatomy. We want a certified interpreter who knows terminology. So let's move towards this. We also want to instill a sense of safety in that sponsor. We want them to know, okay, your kid, the kid you're bringing home needs a plan. They need to know what's going to happen today, tomorrow, and you may not know that, but communicating constantly, hey, we don't know when our court date's going to be, but I assure you, I will let you know. In the meantime, I am here for you, and this is our plan for today. This is our agenda for today. Kids need to know what's going on. Uncertainty is one of the biggest risk factors for down spiraling into depression and anxiety and PTSD. And finally, we need to have ready to go materials printed so that we can hand out common reactions in kids, what is trauma, and behaviors to be on the lookout for. You might be talking to a sponsor or a caregiver and the kid is looking fabulous, but you might want to give, hey, heads up. If you start noticing bedwetting, if you start noticing aggressive behavior, changes in patterns of sleep and eating, these are the signs that you want to look out for that we might need to connect this kiddo with services. And here's a list of who you would call. As I mentioned, the National Child Traumatic Stress Network, nctsn.org, has a plethora of resources ready to go in English and Spanish, fact sheets, tip sheets that you can provide psychoeducation to anyone. And they keep adding stuff, so please check it out. For example, here's a basic one for parents. Here's another one specifically about sexual abuse. The Hispanic Latino MHCTC website has phenomenal fact sheets as well that I'll show you that you can use. And my final point of discussion, and then we'll go into Q&A and more conversation with this wonderful panel, is we need to start thinking too of the best way you can provide care for unaccompanied minors and their caregivers and their sponsors and your coworkers is by taking care of yourself. I remember my graduate training was 100% with adults. In fact, I was working with domestic violence offenders in prisons. My entire dissertation was focused on developing evidence-based treatments for this population. And I remember that moment where everything changes, where these men in prison, adults, looked at me and said, Rosaria, where were you when I was a kid? And that transformed my worldview completely. 100% of my dissertation sample had experienced themselves violence and trauma when they were kids. And here we are trying to intervene at the end of the spectrum. Worthy, noble cause, but is it where we need to start? No. So I respecialize in working with children, period, and trauma during internship and postdoc. And the reason I'm telling you that is because my first year of working exclusively with trauma-exposed kids was hard. And I didn't know that I was experiencing what's called vicarious trauma or secondary traumatic stress. And it's when what you hear, what you see in your job starts impacting you. And I was having nightmares and I was noticing myself being very apathetic and losing hope. And when I realized that that is called vicarious trauma, secondary traumatic stress, and that these were the signs, being irritable, checked out, avoiding work, nightmares, that was the moment where I sought support from supervisors, colleagues, my own therapist, sought professional counseling, and really worked to help that bucket kind of empty itself out so that I could give. So please today, as you are listening to this, practice self-care. And self-care is not doing yoga or eating right. That's part of it. Self-care starts with noticing that you matter. And that if you don't pay attention to these signs, eventually they'll purposefully make you pay attention to them. So we got to take care of ourselves. So please check out this website for more resources. My handouts are in the packet. I noticed Dr. Sayas, folks were asking if your handouts could be included as well. So I am sure that we'll give you those handouts as well. And I'll leave you with this quote from Margaret Mead. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. So remember that. So with that, I'll leave it back to Dr. Sayas to moderate our Q&A.
Thank you very much, Dr. Orengo, and thank you, Dr. Romero, as well. Well, we'll open it up. You're getting a great deal today because ordinarily we only have about 15 minutes, but today we sped up and you've got plenty of time. So perhaps our technicians in the back can tell us something about the questions that are coming in and who the question might be addressed to.
Okay, I'll be doing that. I don't think the questions are specifically addressed to anyone, so I'll just leave it open.
Fine.
And it says, I'm a social worker in Southern California and would like to know how I can be involved in providing services for this unique population. And then she's asking for someone to please point her to the right direction.
Dr. Romero, you're the closest one of us to California. Do you have any suggestions?
Dr. Romero, I think you're muted.
Yep, I'm muted. Thank you. I gotta say, I think the resources and reaching out, definitely you wanna do some research, right? I think we've seen also from agencies here that are trying to recruit social workers. It's been very interesting through text messaging and other things. So without giving you a specific name of an agency, what I would do, Catholic Charities is one that is typically involved. They're one agency that reached out to us as a center as well that I would maybe start with, but I would recommend just do your research, know what the intent of that agency is about. We do have, unfortunately, a lot of, I think, agencies that at times are for-profit that may be looking for opportunities to gain revenue from this crisis. So I always just say, just do your homework, make sure you attach yourself to an agency that is going to do exactly what was just shared with you in terms of self-care, right? Supporting you through that effort. I was very much able to experience this for myself, the specific behaviors that Dr. Orengo just mentioned in terms of vicarious trauma. I was a counselor after 9/11 in New York, and we were able to access or help a lot of children speaking Spanish only and families, caregivers only speaking Spanish access services after that traumatic event that we experienced. And many of the providers there started to become what I called crispy critter, right? They were very crisp, they were burnt out, they were experiencing very similar symptoms to what were just described. So do your homework and make sure that whoever you attach yourself with, and you're more than welcome to follow up with me. I just included my email in the chat, and I can definitely help you maybe look at screening some of those agencies that you're reaching out to and have that further discussion.
Yeah, and Dr. Romero, I want to echo the importance of, do your Google searches, call up people. I would say the Serving Children and Adolescents in Need scan. They're in Laredo, Texas, funded by the National Child Traumatic Stress Network, is a great place to call up. This is their bread and butter. They're vetted, and they can point you to a great organization to connect with. And that's in the chat as well.
Awesome.
Other questions, Dr. Miranda?
I was just gonna say thank you both for the answer. Yeah, and someone actually suggested, along with the first question, about a place in California called Endeavors, which is a nonprofit working with immigrant children and adults. So there's that info. And I just wanted to quickly say it as well, for people that might not know, you can just submit questions in the question box. And yeah, we're getting more now. So let's go with the next one. It says, I work with DCPNP and I have an 18-year-old that came by himself to the US. How can I best engage with his resource mother in explaining that this child, now an adult, came with a different mindset to the US?
I can start us off with that. That's a very common, concern that providers have, right? So one of the things that I try to do with my moms and caregivers coming and seeing a teenager who's not the same kiddo that they left, and is first checking in with them on what are your expectations? What do you remember? What do you expect to hear? And then I would gently provide information on, do you know anything about what this child could have experienced in the last couple of years, or immigration journey? Just do an inventory, and then provide general psychoeducation on what most kids go through, not saying that this kid went through that, and common reactions. And one of them being that they might feel like they're angry, they might feel like they might have different cultural views and norms and expectations, and then facilitate a family session where we provide empathy and support. So really it's listening, validating, providing psychoed. I don't know if my colleagues want to add anything there. It's a very common occurrence.
Sure.
Yeah, I would like to add to that. Thank you for that. I think the other pieces that I would add is just be aware of what are the normal developmental stages, like was just mentioned, right, of an adolescent and a teen, and see how those are exacerbated or more prevalent in terms of the behaviors that are obviously around doing harm to the young person or to others. But I also see it from a perspective of also understanding what sort of messaging is that young person receiving from their social media outlets, their school, whatever systems they have involved with them. Because I think a lot of times the acculturation process happens, and many times the young adolescent or child acculturates at a much faster pace than their caregiver, especially if it's grandparents raising grandkids. So I think a lot of times it's kind of reconciling kind of that information that's being gathered so rapidly through smartphones, social media, and otherwise, and really getting a sense from the young person of, what sort of messages are you receiving about yourself, right? As a Latino who has immigrated to this country.
Let me just jump in and add this to what my colleagues are saying. And that is that I think we've got to look at many of the children who are coming from Central America these days as having a slightly different developmental trajectory. In their countries, by 13 or 14, they're already considered adults. They're the activities, the expectations, look at them. They came across perhaps by themselves with groups of others from Guatemala or wherever, and through Mexico to the United States. And they have gotten themselves here. They have managed their lives. Back in their home country, they might have been the breadwinner, if you will, of the household. And when we see them, we've also have to understand that that's their background, and that doesn't mean that we necessarily immediately adopt that cultural paradigm that they are adults, but rather to understand, because that's what's going to tell us something about how they respond to us, how they respond to the world around them. So you may have resistance, for example, to do things, to follow orders, because after all, they didn't have to follow anybody's orders or requests. They dictated them in their homes and in their communities. So that is something that we really have to be concerned with as we speak to many of these children.
Thank you all for your responses. Our next question is for Dr. Zayas. And they said, great presentation, and thank you so much for devoting so much work to an important issue. I was wondering if Dr. Zayas could touch on how the attachment problems could affect individuals in this population long term if left untreated.
Thank you for asking that question. I couldn't have paid you more to ask it. But we do know that the experiences that these children have had will not go away. They're not memories that we erase or even repress. As Dr. Orengo mentioned, they're going to be with us, and they're going to come back in the form of all sorts of symptoms, sudden rushes of memories in the mind at the least expected times and places, but things that remind us. We have got a lot of work ahead of us, because we do know that untreated stressful events, traumatic events, as they accumulate, so-called adverse childhood experiences, they accumulate. The damage that's done both to the brain, but also to the emotional spirit, right, to the personality that the child begins to evolve, are really very important. We're going to see those. We're going to see them, for example, in relationships. How close do I let myself get with this person? Might this person hurt me? Can I engage with this person in a romantic or close friendship? Can I trust this parent who left me? All of those things will stay with them and impair their social relationships and lead them to be with others, or perhaps alone without others. I think that's vital. We've got to think about the way they think, their executive functioning, things like the tasks that they have to concentrate on. Can they concentrate? Can they put step A before step B before step C and do things that we take for granted commonly? Those are the sorts of things that can be damaged in the brain long term. And without intervention, we could see problems in educational achievement, occupational performance, simple things around the house, completing tasks, following lists, to-do lists, or honey-do lists, as we call them. Any of those will be the lifelong occurrences. That means that we've got to take both target the emotional sequelae of the experiences, but also the psychological, the cognitive, right? How do we help them? Not unlike when we're working, say, with a child with attention deficit disorder. We will find all sorts of ways for that child to hang on to something, some structure that is created that they can follow, whether it's where they put their socks, a place that's labeled, or what they do first in the morning. So we make lists. We may need to work with our clients using those kind of cognitive behavioral interventions. I say interventions, they're not necessarily formalized treatments, but rather just cognitions, how we have people think about their day and how they're going to break it up, and then of course create means by which they can achieve them. And that's how we're going to do it. So there's the emotional, there's the cognitive, and of course ultimately the behavioral component. One of the things that happens with this type of adversity is the dysregulation of emotions, the sudden volatility in emotions, the liability of emotions. And we're not talking bipolar or anything like that. We're talking about simply managing and controlling one's stress and one's emotion. We hear a lot about emotional regulation. This could be one of the factors. So we're talking about cognitive, emotional, behavioral, and that we need to address and treat it. And it doesn't have to be complicated. It starts in our local communities. We can do these in centers for children, in recreation parks, and things like that. We can introduce it in everyday life to help these kids not let their past impair their future.
Okay. And Dr. Zayas, I added a link to evidence-based practices and trauma treatments that have been cleared by the most rigorous standards, and it's in the chat box. So please make sure to check that out. And like Dr. Zayas said, there is specialized treatment, but there's also great interventions that anyone can do. And one of them is providing psychoeducation, hope, and support. So please keep that in mind.
Yeah, I think just to add to that, if you guys don't mind, I would just concur that at the core of kind of the content I covered this morning is relational issues, right? Is that disruption in the ability to build trust and long-lasting relationships. As we know, that's part of how we have quality of life and longevity, right? Is through the support of others, many times communal support. So I think those are ways that you as providers can really develop respect and trust as a cornerstone of a foundational relationship, an example of what they should seek post therapy or post psychoeducational. But I think it's about consistency. I think it's about being there and showing up, doing what you say and say what you do. And as much consistency as we can provide to these young people, I think the better opportunities they have to develop sustainable relationships, because we know attachment disorder is real, and we know that is a big part of some of the experiences that are playing out with the exactly like Dr. Zayas shared with the video of the mom, right? These kind of push and pull, get away from me, I need you, kind of experiences with attachment. So I just wanted to reiterate that. Thank you.
Thank you for your responses. And just a quick note, Dr. Rengo sent everything to the question box. Is the chat on our end. but it's the question box on the attendees end, just to clear that up. So our next question reads, do you have a suggestion for someone that will start working at an emergency shelter as a clinician?
And you know, so many suggestions, but I think the first one would be to just check in with your values, right? Why am I doing this? I think that's what I tell my trainees first, because that'll give you that extra shield of support and motivation and values-based direction of why are you doing this, right? And then the other thing is make sure that you are getting all the training you can, such as what you're doing through webinars, through fact sheets, so that you're informed and put on a trauma-informed lens. And then my third tip for you is seek support with colleagues, have a consultation group, have people you can turn to, because a lot of this work you learn on the field and you learn it with great consultation and support from others. And if there's one thing you can do for a kid in crisis, a family in crisis, is be there, show up. We heal in community, we heal in relationships, as Dr. Romero said. So sometimes it's showing up and listening, and then you don't need to know all the answers. Write them down, the needs, and then consult with colleagues so you can best direct that family, that individual.
Okay. So if no one's gonna say anything else, I'll just go ahead with the next one. It says many of us. Go ahead, Dr. Sai, sorry.
No, go ahead with the question.
Okay. Many of the unaccompanied minors that we work with are now over 18 years old. They reunited with their family, had to go to high school, maybe quit high school, and are in the workforce. As young adults, are there any suggestions of how to have a conversation with parents and their children about developing a relationship after being separated for many years and experiencing additional traumas in the US?
Let's see, I heard some parts there. Above 18 and entering the workforce, and then there were other things. The other part of the question was about connecting to the parents. That I want to make sure I understood that, because I got caught on the first part, which is that indeed many of them want to enter the workforce. As I mentioned early, that's all they've known is to work. We do know that in many impoverished countries, education stops sometimes at fourth grade because of the needs of the family for support, and there may not be that element of background education that they can bring, and then that might sustain them into high school. So they will quit indeed. And let's face it, just because they're in the United States doesn't mean that their economic needs end. In fact, they need them, so they have to be able to work. So that's one question. What we can do as providers is try to find ways that the child can continue, or no longer a child, an 18-year-old or older, to continue to work, but find ways to get back to that high school diploma, to that technical training. We do know that just in the U.S. that technical jobs will be abundant in the future. We need all sorts of skilled professionals, and there are those possibilities. Not everyone has to go to college to get PhDs like us three here and others who are listening. But I think that's what we have to help them, to find a way that it's not just a job, but how do you get yourself into a career, a lifelong pursuit that will support you and your family. And that might require stopping, taking some education, or going to evening or weekend schools to get those. With respect to the latter part of the question, unless I split it incorrectly, the matter of connecting with parents, that really is, I see it as a family intervention. It's not individuals. You need to bring the parent, the child, or let's remember too that we've got category A of unaccompanied minors, which are the kids that are going to be placed with their parents, right? There's category 2, which is placement with someone like a grandparent, and within that category there's A and B and others, but that's that next kind of lineage. Then the third category are kids who are going to go to aunts, uncles, distant relatives, fictive kin in some cases. And then the fourth category are the kids who are going to be in our child welfare system in foster care. Now, we hope that the preponderance will be in the first two, but we can't always assure that. And therefore, how we intervene has to be based on what is this family, what are they reunifying as parent and child, grandparent and grandchild, aunts, uncles, nieces, nephews, madrinas, padrinos, and things like that. So we've got to be aware of those relationships and then begin to foment the ties that are important. And I think it's important that the work goes both ways. The child, okay, we expect often that the parent will understand what this young adult has gone through. And we've got to do that. We've got to also have, so we've got the parents to understand why it is, or the grandparents or whoever, to understand why that child is behaving the way they are. Developmental, traumatic, all of the things that they went through, which many parents can and others can appreciate. We've got to stress that they have to understand that when that child, so for example, although it doesn't apply directly, but the little boy who's going away from his mother, how might that appear as a 20-year-old child, as an 18-year-old child? That might be seen differently. It might be what we perceive as withdrawal or indifference, but it's a different form of manifesting that same behavior. We've got to help parents understand that. We also have to help the young person understand what they're experiencing and why it is that their adults who have received them are behaving peculiarly to them, or maybe too obsequiously to them, whatever or whatever they are, because that may be where the stresses lie, in that there's this lack of understanding between the two. And it's pure psychoeducational family intervention. How do we understand each other? Let's hear each other's stories. What stories can the grandparents and the parents and others tell the child that will give them a sense of who they are with and how well they can relate to their stories? And let's hear the child tell his or her story, so that, to the extent that they want to reveal what they can, so that the adult will appreciate the hardships and understand the details of stories that get lost. I'm reading transcripts upon transcripts of interviews that we have done with mothers and kids who have found their way, and the transcripts are fabulous in looking at both the parents' perception of the trip and the child's, and they're not always in sync. What was stressful for one was not stressful for the other. What one saw, the other one didn't necessarily see or report. So it does take a great deal of bringing together and developing the ties. Dr. Romero, Dr. Orengo, do you have more to add?
I would just add, if you don't mind, also to that point, Dr. Zayas, the fact that we have to help families and also the child or young adult understand, based on where their traumatic experience happened in their developmental stages. Sometimes arrested development happens, right, where a child is behaving as if they were younger than they really are, or again, as Dr. Zayas mentioned, based on cultural values of a home country, maybe acting beyond their years, right, and being in a role that is more of a lead in a family. And I think doing role recognition, role awareness within family work, right, understanding how each person within that family has a role, and we have to kind of reconcile and also be aware of who is kind of the leaders within a family, right? Caregivers, parents, take that responsibility away from young people and from children, and I think our ways of adultifying or parentifying young people, really allowing them to be children and understanding what that is like for them as well, as opposed to pushing them to become an adult. And developmentally, emotionally, they may be functioning as a teenager or a middle-aged a middle school age child, right? So I think just understanding those pieces are important as well.
I think we're getting the signal that our time is up. Dr. Orengo, I'm sorry, I have to, I'm sure you wanted to add to that, but We are at the end of our time. I want to thank Dr. Orengo for her presentation today, participation. Dr. Romero, as always, good to see you. There are some folks in the background that we want to thank. I want to thank the St. Mary's Center and the U.S. Committee for Refugees and Immigrants, and we're really grateful for their support. And of course, then there are our friends at the National Hispanic and Latino Mental Health Technology Transfer Center. In particular, I want to thank Dr. Christine Miranda, who's the project manager, and our wonderful tech, our wizard, Cindy Negron. And finally, the person who's the boss of all of us and couldn't be here today, Ms. Carmen Andujar, who would have been here but just couldn't be here. And we know we send our love to her every day of the week. Thank you so much for joining us today. You see there, we're asking for your opinion. Fill out your evaluation forms. Please take a few minutes. This is how we're able to bring these webinars to you. And your input is vital to us. So thank you all very much and have a great day.